Thanks again for joining everyone to this month's edition of the Greater Manchester Connected Health Ecosystem. For those of you who have not joined these meetings before, the Greater Manchester Connected Health Ecosystem is an activity organised by the University of Manchester, the Christopher Pankhurst Institute at that university, and the Digital Futures Platform, Health Innovation Manchester, and the ECH Alliance, the European Connected Health Alliance. I'm Neil Speak. I'm Professor of Health Informatics at the university and also Director of the Christopher Pankhurst Institute for Health Technology Research and Innovation. I'm going to be chairing the meeting today, and the topic is Deep Dive into the Greater Manchester Care Record, connecting health and care across Greater Manchester. We've got a wide range of speakers who are going to talk about the care record, which is a collaboration between a large range of stakeholders, and I'm involved myself and my team in this. And I think it does represent a great collaboration across the region. So just a little bit of housekeeping before we start. Please mute your microphone, and if you could use the chat function for discussion and to ask questions to the speakers. We may also ask you to unmute and formulate your question. Please add your name so we can identify who you are, and feel free to tweet about the event using hashtag GMEcosystem. We are recording this event, so just that you are aware. So the agenda of today looks as follows. We're going to start with a presentation by Guy Lucky from Health Innovation Manchester, who's going to tell us about the background to the rollout of Gmcr in response to COVID-19 and the future development of the Gmcr in the development of the integrated care system in GM. Then Paula Bennett, also from Health Innovation Manchester, is going to talk about clinical difference the Gmcr is making on the front line and its role in clinical pathway transformation. Then we're going to move beyond direct care and look at secondary uses of the Greater Manchester Care Record. So I'm going to give a brief introduction to that. So beyond direct care, the Gmcr and population health research. Then my lead research data engineer, Richard Williams, is going to explain how de-identified data from the Gmcr is used to support research. Then we have an example study that was recently conducted with the Gmcr, presented by Nhs Hassan. That's about COVID-19 mortality in people with severe mental illness. And finally, Daryl Davies from GraphNet, who's the industry provider for the Gmcr, is going to provide the industry partner view. So why and how this has happened in Greater Manchester and how GraphNet have supported the development of the Gmcr. We will then have ample of time for questions and discussion. I expect I can probably give you back about 15 minutes of your life, so I think we will end around 2:45. So without further ado, I'm going to hand over to Guy. So let me stop sharing. And Guy, thanks so much for joining today, and the floor is yours.
No problem. Thanks, Neil. It's a real privilege to be here today. Just as way of introduction, I've got two roles within the system. I'm Digital Innovation Director for Health Innovation Manchester. I'm also Head of Digital for the Greater Manchester Integrated Care System, so a real privilege to be here today. I'm born in Brde in Manchester, went to university in Salford, so please forgive me, Neil's there. I spent about 25 years of my career working for a large tech company, leading and shaping some of the largest sort of digitally enabled transformation programs, both here in the UK and globally. And through that experience, I've seen the power that digital can bring to bear to help tackle some of the wicked challenges we face in healthcare. I've also seen how digital hasn't delivered some of the investment that the outcomes promised, and therefore the investment essentially been written off. And through that sort of experience, I've learned two sort of key lessons in my life. One is that focus on the problem, not the technology, and the solution to that problem involves people, process, and cultural change. So if you spend £1 on the technology, we should generally be spending £3 on the people, process, and cultural change to really enable that transformation to occur. So the reason why I give you that background is I always felt one step removed working for a large tech company, and so therefore 3 years ago I decided to join the NHS, and I'm very privileged.
10 minutes trying to get into this event.
Be privileged to be part of the Health Innovation Manchester team today. So Peter, can we go to the next record? Right. So probably to some overall context of GM, like a lot of places both in the UK and across the world, Greater Manchester faces some very challenging health problems. We've got a diverse population with some complex needs, from below life expectancy for both men and women, and also children disadvantaged from birth. We've also got major significant difference in health outcomes from people from poorer backgrounds as opposed to people from richer backgrounds. And if anybody's read the Marmot report that says you were 2.3 times more likely to die from COVID if you were from a poorer background in Greater Manchester than if you were from a wealthier background. So huge discrepancy there, and so those were sort of some of the key reasons why Greater Manchester became one of the first devolved cities, because the GM leaders recognised in 2016 that the economic power of Greater Manchester was essentially being held back by the health of the population. So there's an intrinsic link by actually ensuring the health of the population to drive economic growth, and ensure there's a direct correlation between better education, better jobs, and better wealth in terms of improving the overall health of the residents of Greater Manchester. Huge opportunity to drive both innovation and job creation in Greater Manchester. For those that know the system, we've got a really good incubator of both large scale and startup organisations, both in the life sciences industry and the digital industry. And a key fact is that we have around about 10,000 open vacancies in the digital space. So digital in itself is hopefully one of the key areas by which, if we're able to upskill our population, then we've certainly got the opportunity to help create those new jobs that are directly related to health. Next slide, please. Okay, so Health Innovation Manchester, the role of Health Innovation Manchester really in a nutshell is to accelerate innovation from academia, from healthcare providers, and from industry to frontline staff. And we operate across the discover, develop and deploy life cycle. So that includes acceleration of new molecule development in drug manufacture, all the way through to the delivery of digital tools to transform health and care services. Next slide, please. Okay, so one of the key elements that Health Innovation Manchester is really focused on is the power of digital to sort of transform health outcomes. And during the pandemic, we've seen a real deep acceleration of the work that we've done across the board in digital. And this slide shows you some of the major work that's been done across the system in terms of accelerating that particular agenda. We've learned some real key lessons through that process. One is, we need to focus on a number of key priorities. Second is that those priorities need to be agreed at the top of the shop and have real cross-organisational ownership to enable them to be successful. You need obviously money to be available, and then you need to be able to deliver what you say you're going to deliver and be really transparent in terms of how you deliver it. One of the key elements that we've really accelerated is the Gmcr record, which I'm proud to introduce today in terms of the level of acceleration that we've done through this process. So Peter, next slide, please. So one of the key things that, I don't know if anybody's read the ICS white paper, which is the call to action in terms of what integrated care systems need to support. From a digital perspective, there's a real call for a number of key pivots that need to happen. And one of those pivots is to ensure that digital strategy is absolutely subservient but informs sort of clinical transformation. So it's not seen as a technical thing that sits in the back room, but essentially a key enabler to the service and transformational improvement agenda from the NHS and social care more fundamentally. Is a specific requirement to develop an ICS-wide shared care record, and I think it's fair to say that we're probably one of the most advanced systems across the UK in terms of the work that we're going to demonstrate to you today. It also goes, well beyond the sort of the installation and sharing of record, but really using that data and that capability to transform existing pathways. Those pathways and transform those pathways around the citizen and the patient, rather than actually, transforming the pathways around specific services. Obviously, a key element that we're also going to share with you is the power of population health and how we start to use analytics to really focus on the areas of greatest need. Next slide, Peter. Okay, so this is all sort of led to one of the key accelerations that we've done around the Gmcr record, and just provide you some context. Paul is going to provide more details, but think of the Gmcr record as sort of as an integrated view of all your care that takes data in from a whole range of different care settings. So it takes information from your GP records, from your acute hospitals, from specialist hospitals like the Christie, from social care, from ambulance and emergency settings. So huge rounds of sort of inputs. During the pandemic, one of the key things that we've been successful doing is really accelerate the deployment and execution of that Gmcr record. So pre-pandemic, each of the Greater Manchester 10 localities, there's 10 localities in Greater Manchester, for example, Salford, Manchester, Bolton, or example, 3 different localities. Each locality had their sort of own version of the Gmcr record, and we had around 2/3 of the GM population on that platform. And as part of that, we had some pretty complex data controller arrangements in place. So through the pandemic, we've managed to sort of accelerate the move of those 10 locality views of the data into a single view of the data. So what that means is essentially we've removed the walls of the data. So what it means now is that if in any care setting across Greater Manchester, if a Manchester resident showed up at a Salford A&E department, the Salford clinician could actually see the record from that Manchester resident. And we've got to around 99.9% of the records onto the Gmcr record, so a huge acceleration, so nearly 100% there. And we've done some real heavy lifting in terms of building a trusted ecosystem to get to a single data processor and information agreement, which I'm sure Paul and others will talk about it. And that's for both direct care, and we're just about to finalise that agreement for secondary usages as well. Fundamental to that is actually ensuring that we've built the right infrastructure around providing transparency to both the public and data controls about the use of data through that process. Next slide, please. Great, so now I'm just going to hand over to Paula to give you the more in-depth view of the Gmcr record. But a closing remark would be that I think, the Gmcr record is now a major strategic asset for transformational change. We are developing a range of transformational use cases which are there to enable integrated care and join up care between cross-organisational settings. And also we've got a deep portfolio of research studies that are actually happening on the record, which we're going to find out more about as we go through the session today. So it's been a real privilege and honour to be part of that journey to date. And I'd like to hand over to Paula. Paula.
Thanks, Guy. Good afternoon, everybody. Again, just to echo what Guy said, a privilege to be here and describe the clinical impact of the Gmcr record. My name's Paula Bennett. I'm the Chief Nurse and Chief Nursing Information Officer at Health Innovation Manchester, and I've had a 25-year-long clinical career in Manchester in emergency care. So I really understand the challenges, particularly on a non-elective urgent pathway, to gain information very quickly about the patient that might be in front of an out-of-hours GP or an emergency department doctor, or you know, mental health nurse in an emergency department overnight. And this is, you know, part of the difference that the Gmcr records made. And I'm going to take you through some of the functionality just to kind of bring that to life for you. Next slide, please, Peter. So as Guy said, we've now got one shared care record in Greater Manchester that shares the information without any artificial boundaries for nearly 3 million citizens. And that's having a significant benefit for direct care wherever a patient may present. So whether that be an outpatient clinic, whether it's in the GP practice, whether that's in secondary or tertiary care. We know that the GP holds the master record for the patient, and all information from secondary and tertiary services feeds into the GP record. And with individual shared care records at a locality basis, you would have had access to that information at a locality. But as Guy mentioned, as patients move around the system, so they might be having their renal treatment at another hospital, that hospital wouldn't be able to see perhaps the tests and investigations that had been done more locally. So what the Gmcr record as it is now has enabled that sharing of information, which is able to transform pathways and also provides a huge repository of information for population health and analytics. And I know there are more talks about those as we move through this webinar today. Next slide, please, Peter. So I'm sure there'll be some of you here today who don't have access to the Gmcr record or might not have used it for a while. So essentially, as Guy said, there's information fed in to the Gmcr record from multiple source systems from over 50 different health and care organisations across Greater Manchester. So acute trusts, general practice, mental health trusts and local authorities, so social care social care organisations. And you see displayed, once you are in a patient's record, various key pieces of information. Medications, and that would include allergies, test results. So those would be test results not only done locally, but anywhere across Greater Manchester. So pathology and radiology, and soon images will be available within the Gmcr record, along with detailed pathology reports. Care plans, so if there is end-of-life care planning within the Gmcr record, then there's access to that. And we're also developing more multidisciplinary care plans, which I'll talk about later. And social care information is within the record. So if somebody presents perhaps out of area, who's got a particular package of care and a named social worker, that information is in the Gmcr record, hopefully with a correct contact number, so that you can immediately contact that social care professional to get some more detailed information, or perhaps plan a rapid discharge for somebody. Now, most of the information is live, so acute provider information, that's a live update. So if somebody's in the emergency department, you can see that in the Gmcr record. For the general practice data, most of that's an overnight feed. So you should be able to see, you know, very rapidly the accurate up-to-date information of the patient. Next slide, please. So Guy showed the transition pre-pandemic to today in terms of moving from 10 records to 1 record. This slide just demonstrates how that's increased the user base. It's increased the discrete logins, and it's doubled the number of records accessed. And we're still working on improving that even further. Historically, some localities had had a shared care record for a number of years, so 7, 8 years. So in that locality, the use was very high and they were a mature system, where other localities in Greater Manchester may have only had a record for a couple of years. So our next programme of work, which I'll come to at the end, is about standardising some of that usage and functionality across the whole of the record. Next slide, please, Peter. So just to get into a bit of detail now about some of the clinical functionality. And this slide represents 2 pieces of additional functionality that we added as part of the response to the pandemic. So there was a new tile or an icon. So this is the row of tiles on the landing page once you're in a patient record. About the patient's COVID status. So if we can remember back to that first wave when we were starting to do testing, we would be able to get information back into the Gmcr record about the COVID status of a patient, and then more later their vaccination history. So again, for people who are critically ill or have cognitive impairment and aren't able to easily communicate, or who are very distressed, we can access that information if they're not able to communicate it easily to us. And we've got 2 pieces of remote monitoring functionality within the Gmcr record, which we introduced as part of the pandemic response. One is for COVID oximetry at home monitoring. So for patients who may be at higher risk of deterioration from having COVID, who aren't unwell enough to require hospital treatment at that point in time, but need more closer monitoring. We've got a platform and functionality within the Gmcr record where they can be monitored remotely, and through a patient app they can enter their saturation information and have phone calls and monitoring remotely to identify if they're on an improving trajectory or if they might need further intervention. And the other piece of remote monitoring functionality are for those ladies who have got high risk pregnancies. So for those who may have hypertension related to pregnancy or gestational diabetes, we're now able to monitor those ladies remotely, and that reduces the need for them to have face-to-face contact, and of course the risk of coming to hospital and perhaps being infected with COVID or being at a higher risk. Next slide, please. Just some information here about how we are able to share information about end-of-life wishes. We changed some functionality to pull through some GP codes into a tile that the ambulance service were able to view about whether a patient had an end-of-life plan and what their wishes were if they were in the at the end of their life, so perhaps where their preferred place of death was. And that enables the paramedics through their help desk to have access to that information and treat the patient accordingly. And also social care, not only can health professionals access social care information, but of course social care staff can access health information, and that enables them to have a fuller picture of the needs of patients, and particularly for patients who are vulnerable and might not be able to remember all their health information, then that provides additional support for them. Next slide, please. We've also got functions that enable the sharing of information about cancer care and treatment. And we have a tile within the Gmcr record which provides the information from the Christie Hospital. So current chemotherapy treatments, investigations, results of those, follow-ups, consultants who are responsible for the care, and that enables quicker decision making. It provides safer care for patients, and it critically saves time for staff. Next slide, please, Peter. So in terms of the functionality, I've mentioned most of those on this slide. Some of the current developments within the Gmcr record and on our future roadmap are around the development of specific integrated care plans that can be accessed by the multidisciplinary team. And the examples on this slide are for patients with heart failure, for patients who are frail, and for those that have dementia. And this is where we can really harness the ability of digital to transform care pathways, where we can share real-time information, not only the clinical information and the treatment plans and the escalation plans, but critically the information from patients about what's important to them. And we're developing those functions this year. And the last slide, thanks. So this is just to describe a paused piece of work which will be restarting again in June. And we've got a roadmap of some developments, and those are things that have been in the kind of pipeline for some time. But we also want to sense check now where we are with the Gmcr record for direct care, not only in secondary care, but in primary care and in social care. And we've got 3 programs that are looking to understand in detail from frontline staff and of course patients and families how their information is shared, what information is accessible, how user-friendly the record is, and what's in there that's very valuable that perhaps isn't accessed widely across the whole of Greater Manchester. So how can we share the insights from those systems that are well developed across those that are less mature? So this programme is seeking to understand through deep frontline staff engagement the care record and its use and what else might be needed, so that we can then make sure that the developments of the Gmcr record for direct care are absolutely clinically driven, and that we've also got insights from patients and carers about how they want their information shared and the things that are important to them. And I think that's the end of my slides. Thank you.
All right, fantastic. Thanks so much, Guy and Paula. Paula, I think your presentation really shows that, you know, the Gmcr record is so much more than just bringing information together. It's really about indeed transforming those care pathways. And I think the examples are all fantastic, are really great. And also the stuff that is still on the agenda to be done in the future are all, I think, very exciting. So thanks so much for that. We've got a lot of questions actually in the chat. So I suggest we try to go through those now, or at least most of them, before we go to secondary users, specifically research. So I'm just going to have a look at them. So the first question is from Brian, and it is about the Nhs Product Program, which I actually do not know. So Brian, maybe you want to unmute and ask the question. I think, Guy, this is perhaps one for you.
I don't actually know very much about this either, but I know that there's a plan within the NHS to share records between, I think it stands for pharmacy, optometry, yeah, dentistry, ambulance service, and community services. And it just sounds quite similar to what's happening with the Gmcr record. And I was wondering, were the two things related in any way?
Yeah, do you want me to? I'll have a go at answer that question. So yeah, I think PolDAC is the intention to do it. I think the reality is that you need programs of work to enable that to occur. So so PolDAC is sort of, in my view, an investment vehicle to enable that to occur. The way that we will do that in GM, for example, is via the Gmcr record. So one of the next things we're doing is is we're running a deep engagement process with pharmacy in particular, and especially community pharmacy, to understand what's the compelling case for action to give access to the Gmcr record to community pharmacy. Yeah, so it is all sort of interrelated, but yeah, think of the Gmcr record will provide a key foundational building block to enable POLDAC to occur.
Thank you very much.
Right, so next one is from Matthew. So Matthew, maybe you want to unmute and ask your question, which is around digital accessibility and digital inclusion exclusion. If you're on the call still, Matthew. Anyway, so Matthew's question is, and maybe Guy or Paula, you can address this. Has there been any work done on digital accessibility, so impact of digital systems on inclusion/exclusion, specifically in the context of GMCR?
So well, we're doing a specific, so the Gmcr record enables us to identify groups and individuals that are currently excluded in terms of data. So in its inherent capability, there's a population health element that enables us to sort of provide a much more intelligence in terms of understanding the population. If the specific question is the Gmcr record itself, does it comply to all the accessibility guidelines? I think we're still reviewing some of that. Some of those are quite complex to actually deliver and execute. I know Daryl's on from GraphNet, so I don't know whether there is a specific, Daryl, where you've got a specific position around how you know specifically accessible it is according to the relevant accessibility guidelines. But I think the answer would be, from my cuff, is that it's reasonably compliant, but not compliant in all areas. In terms of the broader access, I think there's a question that's going to come on to, which is about access. Currently, access is restricted to clinical staff at the moment. We're working to enable access of the Gmcr record to the general population, i.e. patients, citizens, and we're working, the way that will be done is via the NHS app. So you go into the NHS app and the data will be surfaced in a similar, seamless way, of which then obviously we go through the accessibility guidelines through that process.
Great, thanks, Guy. Yeah, so I think that also directly answers Hannah's question, which was asked a little bit later. So can patients access the record? Not yet, but soon that will be possible indeed. Okay, so then a question from Issa. Where does the medication information come from? What role do pharmacies play in the GMCR?
So Paul, yeah, I'll go first and you go. So the medication comes from the GP medical record, which should be the sort of single source of truth for the prescribed medications. As it relates to as I say, we're doing a deep piece of work with pharmacy to understand what value there is in making the GMCR available for pharmacy to review the medications at the point of dispensing. We're also doing a piece of work to see the role of Gmcr record with respect to the take-home medications from secondary care into direct ordering into community pharmacy. But there's some technical things that we need to overcome through that process, not least that most of the secondary care prescribing systems do not support electronic prescribing in community or primary care, because they only work on, I think it's on a dosage and a drug rather than tablet and form or quantity.
Yeah, thanks, Guy. So then a question from Phil regarding pathology. So I think, Paula, you mentioned that images will be integrated. So what kind of images does this include?
So Guy might be able to add to this as well, but my understanding, radiology images, so plain x-rays, and that's the initial plan, isn't it, Guy?
Yeah, so we're still working through the details, but essentially we have, for those technically amongst you, is that all our imaging goes into a single PAC system. So that's MRI, CAT scan, X-ray, and that all goes onto a vendor neutral archive. We're going to provide access to that PACS system as a viewer from the Gmcr record to be able to see whatever images are available in there through that mechanism. We're just working out what the image types would be. So is an endoscope video, for example. Echo and cardiac are slightly more complex because they're generally sort of more niche systems, and we're still figuring out how do we expose that sort of data, because the more sort of departmental systems which are quite complex to integrate into the Gmcr record.
Right, thanks. So there's a couple of more practical questions. So perhaps one of you could pick this up. So there's one from Heather, for instance: how do I access actually the record? I work in a hospital and I've never been told how to access it. So maybe we can do that via the chat. There's a question from Amy: how promptly is the record updated? And probably that's one for Daryl to address.
Niels, I can quickly answer both of those questions,
okay,
if that's okay.
Yeah.
So, and I didn't mean to mention that actually at the beginning of my slide, so thanks for the prompt. So in provider organisations and in primary care, so through the patient's record, there's what we call a single sign-on link. So if you are in Paula Bennett's record in all scripts at Salford Royal, there will be an icon or a link somewhere at the beginning of the record that you click on and launches you directly into Paula Bennett's record in the Gmcr record. So it's interesting that, we know there are still staff who don't know about it and don't know how to access it, and that's part of this work that we want to do this year, to understand why that happens and what we can do about it. But I think the first thing you would need to do is go back to your own local IT help desk and ask them about access to the Gmcr record. And I've forgotten what the second question was now, Niels, if I've got time to answer it.
How promptly is the record updated?
Oh yes, so real time for acute feeds and overnight for general practice.
Right, thanks. Good. There's a question from Dora about patient access, but we've just discussed that's not happening yet. So that's going to happen in the future. Then from Jim: end of life care record. Great to hear. No, that EOL, that's not end of life, where is it? Well, great to hear that your ambulance team can view the Gmcr. Is that directly within the vehicle or in the dispatching center?
Yeah, at the moment it's the dispatching centre. So the call handlers are able to access it and feed the information to the paramedics. So that's just the first step really before we increase access to frontline paramedics.
Yeah. Well, then a challenging one from Chris. How do you validate the quality of the data shared within the Gmcr record?
Do you want me to start that, Guy?
Yeah, you start that, Paul.
Yeah, so the data quality of the information within the Gmcr record is the responsibility of the organisation where that information originates from, so be that primary care or secondary care. And I can see our colleague from Health Innovation Manchester on the call, newly appointed Matthew Carpenter, who's our Gmcr record data quality manager. So he's just pulling together a 12-month data quality plan to work with the localities and organisations to understand the current status of the data quality and then plan what needs to be done to improve those areas. Yeah.
Thank you very much, Paul. That's great. Thank you.
And sorry, Paul, just to add, I think the other key thing that we've done is actually standardize a clear data feed specification for each of those data feeds. So it's not, so we know what good looks like in terms of the data that we want in there. Obviously, so that's a field by field view. The question really is what is the quality of the data that's being carried in those fields? That's the question that Matthew's trying to answer. So structurally, we know what data is in there. The content actually is where the rubber hits the road, which is the piece of work that Matthew's doing. And obviously what we're trying to do is use coded data wherever possible into the record. And as an example around where that standardization starts, it has to start at the source. So you probably, let me take a very specific example about PCR tests. So PCR tests in terms of the COVID tests can have attributed with different SNOMED codes. So at the moment, all those codes come into the Gmcr record and they're represented in the user interface, and the clinician looks at them and says, it's a PCR test from Salford Royal, it's a PCR test from OFT. They're actually using potentially separate codes, but the clinician makes their joint because the description says PTR test. To solve that problem, we need to agree a set of standard codes that are sent in from each of the surrounding organisations. So we're doing that across all pathology and LIMS as we speak, as an example.
No, thank you again. That's very useful to understand. Thank you.
Okay, so 2 more questions before I'm going to move us on. There's more in the chat actually, and please keep adding those questions to the chat because there's going to be more time for discussion later on. But 2 more questions for now. So the first is from Corinne. You mentioned integration of the Christie cancer care data in the GMCR. Can you comment on the integration of other secondary care information in the GMCR? For instance, hospitalization of other GM hospitals. What level of detail is available in the GMCR on that?
Yeah, so there's information in the Gmcr record from all acute hospitals, so A&E admission information, discharge letters following inpatient stay, outpatient appointment information, and some of those feeds from all the different provider organisations are at slightly different levels of maturity, and that's part of the work that we're undertaking this year to make sure that that's consistent across Greater Manchester, because we've moved from 10 records to 1.
Yeah, Paul, just to add some more colour to that then. So if people are familiar with the HL7 ADT, the admission, discharge and transfer messages, those are essentially the event types that come in. And Paul is right, we're going through a process of making sure that they generally are consistent across the piece. The big value becomes in when you actually start to encode the documentation, like the discharge summary, with a standard mechanism of SNOMED coding, which then flows into the Gmcr, because essentially that coded information comes through a different route, which is the SUS data that we get sort of anonymized back through from NHSX and NHS Digital. So there's some work that we need to do to understand how we, like we're doing in pathology, provide a program of work to standardize data feeds, for example, from discharge, which will provide even more visibility of the activity that happens in secondary care, very similar to what happens in primary care.
Thanks. Corinne, do you want to come in?
Yes, if that's okay. I'm an oncologist working at the Christie, so I very often access the Gmcr record to look at my patients' records. And what I've noticed is that very often any information from secondary care isn't there. So just trying to understand going forward, is the plan that discharge summaries will become available, or will we even have access perhaps one day to the entire electronic record of another hospital, or what's the direction of travel?
Yeah, so great. So what you should see today is any activity that's happening in an external, an organisation within Greater Manchester should appear when you go into the Gmcr record. Now, obviously, that has limited clinical value because it just tells you that guy's been in A&E, or I've been in this particular clinic. It doesn't tell you what actually happened within that particular clinic. To your point, that the big opportunity is to provide access to that coded discharge information. Now, there's various ways that we can sort of enable that to occur. Ideally, we should be able to get structured data from each of our acute hospitals that then feed in to the GP record and into the Gmcr. That is a very simple thing for me to say, but has A, technical complexity from each of the EPRs to support it, and B, much more complex operational practice in each secondary care to provide a standard coding structure. So the other key thing that's more easy to do is provide access to the discharge document itself, so to be able to click through and see the discharge document. And there's various different ways that we can do that, which we're working through at the moment, which is much more of a sort of interim before we get to that sort of structured data. So if what you're really interested in is the discharge summary, we potentially have a very sort of interim step that enables us to view that discharge summary, but it'd be like a PDF rather than a coded document.
Yeah, but from a clinical point of view, that would be a great first step. But then if we're thinking in the future about doing big data analysis, then clearly structured data would be absolutely fantastic.
Yeah, absolutely. Yeah, and great. You know, ultimately that discharge summary gets coded into the GP record, which then finds its way back into the Gmcr record to some degree. But yeah, absolutely.
Okay, thanks.
Yeah, and Corinne, there is a pilot going on in Salford, led by Will Dixon, in rheumatology, where we integrate all that information and also use text mining to extract diagnosis and prescriptions, as well as other information, quality of life information from the outpatient letters. And I think, you know, that technology is at a level of maturity where you can actually start doing that at scale. So if the pilot is successful, I hope we can roll that out more broadly across other specialties and other hospitals as well. Okay. Thanks. Okay, final question before we move on from Ange. So Ange, do you want to unmute and ask your question?
Thanks, Niels. Yeah, so as quite a few people on the call know, we've been doing quite a lot of work thinking about electronic patient records and actually how we integrate this much more widely into training of healthcare professionals much earlier in their training. I noticed Kurt and Brian are on the call as well. So we're doing quite a lot of work looking into this at the moment. We began a conversation with Lloyd and Health Innovation Manchester around this. So I guess I was just quite interested to see what training's going on at the moment with current healthcare professionals. You know, it touches on all of what we've discussed around the data quality, the coding, all of that kind of area. If we can't embed that early on in training, then we've got people going out into practice. They don't know the systems, they don't know the importance of the data quality issues, the governance, all the rest of it. And so, you know, you don't end up with useful data at the end of it. So it's really important that we emulate whatever training is going on in practice and think about how to do that much earlier on as we train our future healthcare professionals. So I don't know if Paula or any of the rest of the team have got any kind of comments on that area, really.
Yeah, I can come in. I think at the moment, we don't fully understand what training is happening across Greater Manchester because it was originally devolved down to locality level. And we know localities with high usage have got established training programs and have got dedicated teams that deliver that, but not all localities have got that level of resource. So again, what we want to do this year is understand what training is available, the quality of that, how can we provide training once and enable that training to be standardised across GM, and that wouldn't just be for clinicians in frontline, it would also be for all our healthcare professionals during their training. Yeah, so it's on the roadmap. Yeah, absolutely. Yeah, thanks.
Yeah, I suppose just to add to that, I mean, one of the other things, Angie, that we probably just need to be cognizant of as well is the integration of that training with the rollout of the sort of EPR. So to put it into context, GM, between MFT and Salford Royal will be upskilling 50,000 healthcare workers around the electronic patient record. And what we need to make sure of is that the training on the GMCR is not something that's aside, but sort of interwoven into their operational sort of practice, as opposed to just doing GMCR, then, you know, Epic or all scripts. So I think that's the magic thing that we need to bring together. Yeah.
Yeah, absolutely. I think one of our big focuses, Guy, is around being agnostic of the patient record system. And I think that's a really important thing that I know we've discussed a lot with, you know, this is an example, but I think, you know, it's the principle that applies, isn't it?
Yeah. I mean, yeah, absolutely right. I mean, we could debate for ages. The print, you know, what the rubber hits the road is that somebody needs to know where the icon is, though, on the desktop to click there. Do you know what I mean as well? But yeah, absolutely, can agree more.
Okay, fantastic. Thanks so much for that discussion. Really good, I think. There's more questions in the chat, and please keep adding them because we will have more time for discussion later on. I'm now going to move us on to the second part of today's meeting and look at secondary uses, specifically research with the Greater Manchester Care Record. So let me start by sharing my screen. So here we go. So over the pandemic, we at the university have been working very closely with Health Innovation Manchester and other stakeholders across the system to make the care record available also for research purposes. So this is an activity carried out at the site of the university by the Pankhurst Institute, and it's resourced through 3 pieces of NHR infrastructure: the Biomedical Research Centre, the Applied Research Collaboration, and the Patient Safety Translational Research Centre. So in order to make the care record available for research, it has been a replica, basically, of the database has been migrated to a secure public cloud data platform, the GraphNet Care-centric BI, for secondary users, including research. Previously, that was only COVID-19 research. We're at the final stages of having a DPIA in place, which enables all types of research to be conducted on the Gmcr. So I've written it's now all research. I think it's fair to say in a couple of weeks, probably we're able to make that happen. So within this platform, virtual machines can be set up to give researchers access to bespoke subsets of the Gmcr database. And we've got a team of research data engineers that create these subsets, these data sets. So they are study specific. We never give people access to everything. We have a conversation with them. They describe what they need for their study. And then we create that specific data set for their study. So Richard is going to talk after me. He's the lead research data engineer, and he will tell you more about that process. All the proposals are reviewed by the Secondary Users and Research Group, the SERG. And it has happened that that group has said, well, this proposal is unclear, or it doesn't have, at the moment, sufficient quality to go forward. So with those comments, it was then sent back to the principal investigator for revision. So there is quite a bit of scrutiny that happens before the studies start. Still, the process is fairly quick. On average, I think we can give people access from the day they start with, formulating their proposal to the day when they have access to the actual data. Typically, that happens within 3 months. So I think that's pretty good. It's important to note that the data never leave the secure platform. So all the data analysis are conducted within the virtual machines. We can't share the data. We can't send the data to people. That's not possible under the DPIA that we have, but we can give people access. So what types of studies can we do with the Gmcr? Now, first of all, and so far this has been the most important category as well, we can do epidemiologic and public health studies. And there's many examples that you can think of. We're going to see an example in a couple of minutes. So after Richard, Lamise is going to talk us about a study that she's done on COVID-19 mortality in people with severe mental illness. And we've had a large number of studies in this category. And obviously, a database like the Gmcr is a fantastic source of information for these types of studies. But there's other things that we can do as well, which I think are really exciting, and typically they require a little bit more work, but then what you get is very exciting. So we can also link the Gmcr data to data from hospital EHRs. And Corinne is on the call. She just asked a question about what is available about other hospitals outside the Christie. But we've been linking data from the Christie to the Gmcr for a COVID-19 and cancer study that is led by Corinne. So in that study, we've got really deep phenotypes on cancer from the Christie EHR. And we also have very rich data from primary care, so comorbidities, for instance, community prescription, primary care prescriptions, etc., through the Gmcr. So I think that's a really interesting opportunity that we have as well, especially because the Gmcr covers everyone in Manchester. It's not a sample, it's all 3 million. Then we can also use Gmcr to evaluate interventions. An example is a study led by Martin Rutter. I'm not sure whether Martin's on the call, but that study evaluates the effect on diabetes outcomes from a self-management app that was deployed during the pandemic called My Diabetes My Way. Again, that requires a bit of linkage in order to make it happen. But I think this is, going forward, one of the really interesting things we can do in Greater Manchester, because we have all 3 million people covered in the Gmcr. Whenever we roll out an intervention somewhere in the region, there's an opportunity to evaluate the effects of that intervention very, very quickly. Then there's also the opportunity to run prospective cohorts where we use Gmcr data. An example is a study in pharmacogenetics that's led by John McDermott, and which is run out of MFT. And finally, there's some really exciting work that we're doing with colleagues from GraphNet, where we use text mining to unlock text fields that are normally not accessible for researchers. An example, for instance, are the microbiology reports. So microbiology systems produce reports that, basically due to poor standardization, are only available as text reports, so not as structured data for researchers, which means because they are text reports, they are redacted, so researchers won't be able to see them. What we're doing with the colleagues from GraphNet is applying text mining to translate those reports back to structured information, which is relatively straightforward because they were structured in the first place, and then make that information available to researchers. And we're hoping to also start the first study led by Noir Bakley and Chris van der Gast in a couple of months. So just to give you an impression of what we have done so far and how many studies are ongoing, we've got 2 projects that have been completed. There's 3 that are nearing completion because they've finalized their analysis and are now writing up the results. We've got 7 studies that are in progress, so people who are working with the data and analyzing the data. There's 4 that are in the setup phase where they are creating the data specification and analysis plan. And then there's a further 12, which were proposed fairly recently and are in the either the feasibility stage or even before that. So our team still has to look at the feasibility of these inquiries, and some of those might not go forward. We had people obviously approaching us and saying, oh, I'd love to do this particular study, and we had to tell them, well, I'm sorry, but that data is simply not available, so we won't be able to help you. So we've had a number of studies that for that reason were withdrawn. So in the last couple of months, the first papers have appeared that are based on the Gmcr record. I've listed 4 papers here, and obviously there's a lot more in the pipeline now, so that's really good news. And some of these, I think, are really strong studies. So they demonstrate that this is a fantastic resource for the region and for researchers at the university. So with that, I'm going to hand over to Richard. If I can stop sharing my screen, that is.
I think I can probably just steal it off you.
Yeah, steal it off me, steal it off me.
Yeah, done.
Thanks. Okay, the floor is yours.
Okay, thanks, Niels. Hi, everyone. As Niels says, I'm Richard Williams. I'm the lead research data engineer. I'm going to talk today about what exactly it is that a data engineer does and why it's helpful for researchers. Or at least I would if I could. There we go. So research data engineers, I'll refer to them as RDEs for most of this talk. Between us, we have an in-depth knowledge of the Gmcr database. So we know what it can and what it can't do because we've worked on it for a number of years now for many studies. We've also got expertise in clinical coding and producing clinical code sets. So this would be for any diagnosis or medication, there are many different codes that could be used to represent that, and we're able to curate those and create those sets as and when needed. We've got good database skills, and we know how to write scripts to clean data and prepare it so that it's ready for analysts. We maintain a common and crucially public library of code, scripts, clinical codes, and documentation. So in a nutshell, we provide data extracts from the GMCR to study analysts in a secure environment so they can answer research questions. For the rest of this talk, the bit I'm going to focus on, which I think is the interesting bit, is how we provide the data extracts and what advantages that gives. So for that, I'm going to talk about the difference between routinely collected data and research-ready data. So routinely collected healthcare data, so this is how the data is collected by your GP or by the hospital. And it's collected for purposes of direct care, it's for your treatment, it's not collected for researchers. So what does it look like? It's what we would call a long format. So you have a relatively small fixed number of columns, and as more data comes in, you get more rows being added. So your data gets longer over time as you add data to it. Typically for clinical stuff, each row is going to represent a single event. And so each patient's going to have hundreds or thousands of events, be they a diagnosis or a medication or a symptom within their record. The way we know what it is that each row has a code. So in this example, the second column is the event code. Here it's SNOMED codes. So each of these codes uniquely tells us what the diagnosis was or what the medication was or what was being tested. We also, as you can see in the third column, we have a date, so we know when that thing happened. And then there are optional things depending on what exactly it is. So for a blood pressure reading, for example, that last row, the value is 180 and the units is millimeters of mercury. So that tells us what was actually recorded. Whereas a diagnosis would probably just have the code and the date. Now, research-ready data is different. So research-ready is what an analyst, a statistician, that's the data they are used to working. It's the data that their stats packages like to ingest, and it's the different statistical models they use. It's how they expect the data to be when they get it. And the main difference is that they expect it to be in a wide format. So here, each row, you'd have one row per patient, and if you want more data for that patient, you add more columns. So as opposed to the long format, this is wide, the data gets wider, the more data points you want. Each column is what we call a covariate. So these are all the things that we think may affect the results of our analysis. And so, for example, if we look at the first row, we've got a patient ID, we know their year of birth, we know their sex. We've then got some yes, no flag columns. So whether or not the patient had a COVID death, whether or not the patient's on statins, whether or not they have hypertension. And there might be other things. So for instance, here we've got, that might be the date the person first had a stroke. And this is how the analysts would expect to see their data. The process, the RDEs, we help you convert that routinely collected into research-ready data. And to give an example of the complexity that might be involved here, if we just focus on one of those columns, so whether or not a person is on statins. Now, if you are a researcher or a GP, it's something which you know when you see it, but it can be quite hard to actually write down a set of rules which completely capture what you're trying to do. So if I got a prescription of statins yesterday, then you would probably say I'm on statins. But what if that was a month ago or 2 months ago and I haven't had anything since? Am I still on statins? When did I stop? Also the frequency and the regularity. So if I pick a prescription for 4 weeks worth of statins and I collect that every 5 weeks, then you say I'm not taking it correctly, but I am on statins. Whereas if I was only collecting that prescription every 2 months or every 6 months, then there are clearly points there where I am on statins and when I'm not, and working out what it is to mean to be is on statins then becomes quite complicated. Also, we need to think about what clinical codes are being used. So statins is quite a broad category of medications. There are lots of statins, and you want to make sure you've got every single clinical code for every statin, otherwise you might be missing people. So this brings us on to the role of the RDE. As an overview, here's an example of what would happen without RDEs. So each researcher has direct access to the GMCR data, and they have to work out what's in there. They have to come up with all their own code and scripts. And this clearly isn't working because look how unhappy all those researchers are. So lots of sad faces. So we don't want that. What we do want is our current situation where we have the RDE team acts like a buffer between the researchers and the GMCR. So we're the only people who interact with the GMCR. We work with the researchers to work out exactly what they require, and then we're the people who query the the GMCR to get the data nicely curated in the format they want. And it clearly works because look how happy all those researchers are now. Just to, again, go into a bit more detail about why this is actually useful, let's consider again without RDEs. So research team 1 comes along and they say, well, we've got these 2 covariates we want. We want to know if someone's on statins. We need to know if the person has heart failure. So they think about it, they come up with their code sets, they work out their definitions, and they develop their own logic for these. Research team 2 comes along. They also want to know if someone's on statins, but this time they want to know their studies about CKD rather than heart failure. Now, maybe research team 1 hasn't published anything. None of their code is open, so research team 2 are just completely ignorant of it, so they wouldn't see it. Or alternatively, sometimes research team 1 is quite good and they've shared their code with the world so other people can see it. But even then, research team 2, they can't quite work out what they meant by is on statins. They think their definition is slightly different. So they decide that they're just going to start from scratch and do it themselves. And similarly, the has heart failure, they think there's something they could reuse, but it's so embedded and intertwined with the heart failure aspect, they can't quite separate it. So they end up rolling their own. And then research team 3 comes along, they want is on aspirin, has heart failure, but again, maybe they don't trust what the other team's doing, maybe it's not well documented, so they write their own things. So we're seeing a lot of time wasted, there's a lot of duplication, people are possibly defining things in slightly different ways, which makes it hard to compare. So this isn't great for several reasons. But if we move the situation with RDEs, so now we can maintain a library of stuff. So when the first research team comes along and says, well, we want is on statins and has heart failure, we say to them, well, what do you mean by is on? And we can work with them to come up with a robust definition for what is on means. We then come up with the code set for statins, and then we can put those together and we found patients on statins. We do a similar thing for has heart failure. We work out that having a diagnosis is a thing we can reuse. It's generic, so we come up with this has definition. And then we come up with the code set for heart failure, combine them together and pass it across. So now when research team 2 come along with their requirements, we can talk to them, and it turns out that yes, their definition of whether someone is taking a medication is different to team number 1. So we need to come up with a second definition for is on. But we've already got the code set for statins, and it's the same across both projects, so we can reuse that, put those 2 things together, pass on to research team number 2. Has CKD, we've already got the has diagnosis in red, so we just need to find a code set for CKD, and then now we can pass on has CKD. I think you're getting the idea here, but this slide took a while, so I'm going to labor the point a bit more. Research team 3 asks, we want whether someone's on aspirin, whether someone has heart failure. They want to use the same definition as research team 1, it turns out, because this is maybe a common thing. So we just need to do a code set for aspirin, and then we've already got some of those building blocks already. And for has heart failure, we've already done that. So that's dead quick. We've already got the code. Over time, as more and more studies come in, we develop more and more code sets for different diagnoses, medications, these different phenotypes. And each study progressively gets quicker, and we've got more and more tools available that we've developed in a common way and is publicly available. So just to wrap up, what are the benefits of this approach? First is data minimization. This is a key factor of GDPR. We can make sure that although we have access to everything, the individual study teams only ever get access to precisely what they need for their research questions. It saves time, prevents duplication. I'd estimate that about 80% of a researcher's time working with routinely collected data is in the crunching it and cleaning it and preparing it until they can get to the form where it's ready for analysis. And the analysis, obviously the interesting, exciting bit. We can save that time by us doing it. It means it's easier for the researchers. It also means, because we do this all the time, we get better at it and faster at it, so it saves time overall. It reduces errors. We do make mistakes, probably quite a lot of mistakes, but at least if we make a mistake somewhere and we spot it, then we only have to fix it in one place. It's not a mistake that's going to be repeatedly made over and over again by research teams as they come to that data. And finally, this common library is then publicly available, so it increases transparency, and it allows other research groups to review what we're doing, but also to build on our work. And that's only going to have benefits for open science and research. And that's me done. Thanks, Niels.
Thanks, Richard. I suggest we progress right away to Nhs's presentation, and then Daryl, and then we're going to go back to the Q&A again. So Louise, the floor is yours.
Thank you. My name's Louise Hassan. I'm a research fellow in the Department of Psychology. I'm going to talk to you about a research project that we recently completed using the Gmcr, which aimed to look at differences in COVID-19 related mortality amongst people with severe and enduring mental illness. And what we wanted to know specifically were how mortality rates differ amongst people with different diagnoses, how they changed over time, and start to pick some of the underlying reasons behind this, such as demographic differences, underlying illnesses, and even vaccination status. Just before I continue, just briefly want to kind of step back and consider why this topic is important. And we know that people with severe mental illness already experience poorer physical health than the general population. And that goes for both metabolic diseases like diabetes, but also infectious diseases like TB, HIV, and now COVID. And these can take a significant toll, adding up to 15 to 20 years reduced life expectancy for people on average, which is utterly shocking. So when the COVID-19 pandemic began, there was a lot of concern about how vulnerable groups might be impacted, including people with severe and enduring mental illness. So how did we do it? Well, when we approached Gmcr, we'd already done a similar project using biobank data, which many of you will be familiar with. It's a longitudinal cohort study of people over 50. And though we'd only looked at rates amongst people before the vaccination program had hit. So this paper that we wanted to do at Gmcr was an attempt to build on that previous work in a larger and crucially a more diverse sample over an extended period of time. So what we did is we asked Gmcr for all cases of people with any lifetime history of schizophrenia, bipolar disorder, or recurrent major depression prior to February 2020, which was right at the start of the pandemic in the UK. And this is our sample here. So this diagram shows the overlap between the different people in each group of the SMI sample. So you'll see that people with multiple diagnoses, there's quite a bit of overlap there. They might appear in more than one data set. And we also asked for a control sample matched on age and sex. And we're able to do this at a 4:1 ratio. So collectively, overall, this gave us a really nice big sample of just under 1 million adults, which was one of the reasons why we did choose Gmcr for this work. And then our aim, really, what we're aiming to do was to look at mortality rates by diagnosis. So, and we wanted to compare those SMI groups against matched controls using regression modelling primarily, but also plotting charts over time. And briefly, just a couple of the things that we did to improve like how robust our work was and the precision of these estimates. Because that sample's so large, we had enough power to include lots of covariates in the model. So we produced crude risks and then adjusted the risks, accounting for quite a long list of different demographic, clinical covariates and vaccination status. And we were able to do that, as Richard was talking about, because the RDEs, they drew on existing code sets and performed data validation checks. And that data engineering support is a real strength of the Gmcr in my view. So shout out to George Tilston, who helped us with that work. And we also calculated vaccination status. We got data monthly on vaccination status, so we were able to account for people being vaccinated, and we did that by allowing them a month for the vaccination effect to kick in and then counting it from then. And we also looked at reducing some of the denominators for the overall population when we're looking at rates to account for people who died either from COVID or other causes. So several layers to improve the quality of the work. So moving on to results, a bit of a first look at these because this data is unpublished at the moment. So a total of 5,500 people in our sample died due to COVID-19 up until, that's from February up until September last year, this work goes up to. And for reference, 14,500 people died of causes other than COVID during the same period, so roughly 3 times as many. This figure shows mortality rates and how they varied over time. A couple of things to note there, there's lots to take in, but you can see there's quite clear peaks in mortality in all groups in April 2020 and then over in winter 2021. And you'll see that the highest rates are in people with schizophrenia, so you might not be able to see the writing, but that's the purple line. There's also quite high rates amongst people with bipolar disorder. They're the people in red over time. They're clearly much higher than the controls, which are in blue at the bottom there. And you can also see that line there points out when the vaccination rollout began. And COVID-19 rates, we saw a decline, a significant decline across all SMI groups after those vaccinations started to kick in amongst the population there. This table here shows the crude and adjusted risk ratios for COVID-19 mortality amongst the three groups, again, compared to their matched controls. And the main finding here is that rates were significantly higher across all three groups of people with mental illness, but particularly so amongst people with schizophrenia and bipolar disorder. You can see they're around 3 times as high as their matched controls. And when we looked at adjusted rates, I'm going to flick on to the next slide because I think that shows it a little bit more clearly, this difference between crude and adjusted risk ratios. You can see even after we've adjusted for the effect of all those covariates, vaccinations, demographic variables like age and sex, clinical variables, the risk ratios reduce across the board, but they still remain significantly elevated. So what that seems to infer is that these differences we're seeing between the risk of people with SMI and the general population are not wholly due to these factors that we've measured and accounted for here. So something else going on. And if you're interested in the individual variables, we've done a full analysis of that, and that will appear in the paper that we've prepared, which is currently, like I say, unpublished but under review. So what did we learn? Our headline finding is that even in this post-vaccine world that we're now facing, we're still seeing disparities in terms of COVID-19 for people with SMI. And our findings suggest that these differences in risk are partly, so we can see there's partly down to differences in demographics and underlying conditions and vaccination status. But there's something else there. We need to understand more about the nature, about mental illness, or maybe the risks of treatment that might be affecting this, and in particular anything that might be modifiable and so help us to tackle these additional risks and disparities. Of course, there are the usual limitations to using routinely collected data, but I would say using the Gmcr had a lot of strengths. It allowed us to look at a larger, more diverse sample than we previously had access to, such as the biobank. Fantastic resource, however, has a healthy volunteer bias, so this was quite novel in allowing us to look more deeply into factors such as ethnicity. And also the aspect of it being not quite in real time for researchers, but in terms that you're allowed to refresh your data set. So we published a paper back in January on vaccination rates, and then we were able to refresh the data and do more work ahead of this particular paper, which is definitely an advantage when you're trying to publish quickly in the context of something like COVID. I'd like to thank everyone who's contributed to this piece of work, in particular Joe, George, and also our lived experience advisory group of people with previous experience in mental illness. We've got a couple of papers out and one on the way, so if you're interested in this work, please do contact me. Thank you.
Right, thanks so much, Louise. Great study, I think, and great illustration of what we can do with the Gmcr record in terms of research. I suggest we move on to Daryl's presentation straight away, and then go to the Q&A. There's a number of questions that people have entered into the chat, so we'll answer that after Daryl's presentation, and feel free to enter more questions in the chat whilst he is speaking. So Daryl, the floor is yours.
Hi everyone, I'm Daryl Davis. I'm from GraphNet Health. My particular area of interest is population health, research as well. So I'll be able to answer questions on that later. So GraphNet are a health tech company, UK based. We supply the Gmcr record, and that includes a lot of the things people have talked about today. So that's the care coordination side, remote monitoring, virtual wards. We also supply a population health platform, particularly in GM for direct care use cases. We supply the trusted research environment that Richard and the team have been using. And indirectly, we also supply the national immunisation system in the country, which also generally, obviously, is used throughout GM as well. So our whole business is focused on using tech, in particular data, to help health and social care. So our solutions are deployed to about 20 million of the UK population. So we're out and about around other places as well as Manchester. And our whole focus is trying to improve health and social care. by using data, by either displaying it in shared care records or integrating data with other data to do things like the research. And the partnership that we've worked together with Greater Manchester has been utterly critical to the success of the Gmcr record. So we worked with GM before the pandemic. So we had care records in multiple places. Throughout the pandemic, we've merged them all together into the one great big Gmcr record, which is a fantastic resource, both for direct care and for secondary uses. We also work very closely with Niels, Richard and team to build a trusted research environment, which uses that Gmcr record as a data source. That is still being iteratively expanded as we get feedback from the team to make it better, whether it's adding data, functionality to support research. And we've also done a project with the Christie to support some cancer research, which is basically importing and cross-linking a huge amount of data from Christie to then enable a research project around cancer data and the pandemic. And we also work on multiple use cases for analytics around direct care and the research purposes. So I'll show you a couple of examples of that. So first one, and you heard a brief little bit about it before, is supporting end of life pathways. So that involves data collection from clinicians around Greater Manchester. And from my team's perspective, we then do some analytics, giving summary dashboards of all that EPACS data that's collected and enabling things like drilling through from that to the Gmcr record to get further information. And then remote monitoring. So we do analytics associated with virtual wards, so giving summaries for the clinicians to easily see the status of patients. And again, that can drill through to the care record. So we get involved in GraphNet of building entire use cases from scratch, working with the clinicians out and about there in Greater Manchester. Some of the new exciting ones, which are going to go live in the next couple of months, is sorts of three-way projects. So the first one is Brde, so that's all around antibiotic research. So it's a joint research project with a direct care aspect. So these dashboards can be delivered to the clinicians out there. So, and as well as that, then whether these dashboards have an impact on the actual practice. So it's a kind of an intervention and sort of a piece of analytics that is integrated together with a research project. Smash is another good example of that, one that Richard very heavily involved in. It's an existing piece that's been out and about in a few CCGs in Manchester that we're effectively working with GM to put it into our platform for mass distribution across GM. As part of that, we've just been rewriting the user interface. And again, that's all about looking at prescribing data and potentially hazardous prescribing to improve patient care. So, industry, what do we get out of it? So it creates more joint opportunities for both us, the universities and the Greater Manchester Care System. So we can do joint research funding bids using the data as a resource. We can do the cohort studies Niels referenced earlier. So the Diabetes My Way is one. So you've got a cohort of patients on an app. You can cross-link that data in, look at a cohort of patients using an app or a digital intervention, and then see later on whether that intervention had an impact on the whole care using the breadth of data that's available. Other things are going on. So the massive Goldacre review was published, and it's brilliant to see that we actually do a lot of that in Greater Manchester, working together as a team. A lot of the recommendations are already in place. And we're also working with Open Safety, so potentially the researchers can then run queries across multiple integrated care systems as well. So other things we get out of it as a company, so it fits well with our workforce development plans. Already, we've had 2 student placements from Manchester, working embedded in with our teams. And that model works brilliantly for both the students to get practical experience while they're studying in things like summer breaks or just as full placements as part of things like master's degrees. And we get a potential employee pipeline from that as well. They get practical hands-on work contributing to stuff. As a good example, Niels mentioned the natural language processing project. So we've worked closely with a master's student on that. Then we've worked closely with an embedded researcher, Mai, who's worked actually embedded within our team using our tech. And that hopefully the fruits of that are going to go live very, very shortly. And I can't say more about it. It's people and skills are the most important factor with this. We're a tech company. We can build all the tech in the world, but implementing it, using it, the transformation associated with that is the critical thing. The NHS is hugely short of people who can do this sort of thing. So bringing in the academics, the universities, people like Richard and his team and all the skills that they bring really, really helps. And putting research into action is one of my favourite things I'm really excited to see coming together. So it's basically university researchers working on something that might result in an intervention which can be implemented out in the field, and then we can use the data to evaluate whether that intervention really, really worked. And partnership is, technology, all the things we do, the data quality, there's loads of aspects to everything that people have talked about today. Things go wrong, but working in partnership with people, it's not all sort of waving contracts around. It's about them working together to solve the problems and get going again, to get things moving again. And I can't say more than anything, the GM team are a brilliant bunch to work with. We've really enjoyed working with them, and that really, really helps as well. Thank you, that's me.
Thanks very much, Daryl. Much appreciated, and really interesting, I think, to hear that industry perspective. And as you say, I think it's been a fantastic collaboration throughout the pandemic, and still really useful for all of us, and great partnership. So we've got time for Q&A, and there's still a number of questions in the chat. Feel free to enter more questions during the discussion. I'm going to start with an old one, actually, from Joe. And this is probably then one for Guy or Paula. So will there be a feed from GMMH also into the GMCR, so from the Paris system?
Yes.
Yeah, I think there is already a feed
Yes.
into GMMH into the Gmcr record system today.
Okay, so that's already in place.
Yeah, I think to the point that we made sort of earlier, the question really is that's more around ADT, admission, discharge, and transfer, as opposed to sort of clinic, significantly clinically information, if that makes sense. So yeah, but that message should be in place. We'll double check, but I think it's in place.
Yeah,
today.
it's across the 3 mental health organisations. Yeah.
Okay, thanks. Then there's a question from Stuart. So Stuart, maybe you want to unmute. So it's about how does this compare to other regions?
Yeah, thanks, Nhs. Yeah, I was just wondering, Guy, how on sort of maturity levels, how does GM compare? And just, I was thinking through, given my work is around genomics across the whole of the Northwest, and the patients flow sort of across the boundaries down to diagnostic services in GM, and we tend to find coming in and out of different hospitals across the region. Are the other regions developing similar initiatives? I'm not very cited on that.
Yeah, I think I think other regions. I think there is probably a handful that are probably as advanced as GM with respect to their sort of integrated sort of offering in this space. I think we've still got a reasonably long way to go in terms of driving scaled clinical usage and adoption. So I think from a technology perspective and integration perspective, we are definitely top, in the top 5 of the country. That said, I think we've got use of the Gmcr for clinical decision making from a direct care perspective in pockets, and the program that Paula referred to, the Realising the Potential of the Gmcr record, is actually to work with clinicians at the coalface to say what would really sort of pivot the difference. So if we were going to invest anywhere, it's around the training and adoption, not the sort of technology. But as I say, I think we're in, parking that, we're still in the top 5 across the country around this space, I would argue.
Yeah, great work. Thank you.
Sorry, Stuart, and to answer your other question around the interoperability across regions, there's lots of work that's been done previously and is in flight nationally around how you sort of connect different integrated care records together. To be honest, most of the challenge is not a technical challenge, it's the information governance and getting the data control usage correct, which is the majority of the challenge. So yeah. So hopefully that gives you a sense of it.
Perfect, thank you.
Right, thanks, Guy. So there's a question then from Brian. So maybe, Brian, you want to unmute and ask the question. So it's about access to free text for research, I think, isn't it?
Yeah, so NHS England and Improvement have recently announced that, well, that they're going to free up access to patients to everything that's in their record prospectively from a certain date this year. And I think that's going to change the way the GPs write in the record. And it's especially, I think, going to impact on the free text entry. So I was wondering, is there a way that the Gmcr record could enable access to free text? Not necessarily for the researchers to look at it, even if it's just for AI to compare what the free text entries look like pre-switch on and what they look like after that's happened. Because I think it'll change the kind of the content and style of those entries, and that might be something that machine learning could detect without necessarily a human having to read it.
Yeah, I mean, I think we probably take limited free text information from the GP record into the Gmcr record for the very reasons why you sort of alluded to, which is, sometimes the GPs do want that they're making those internal notes for their own GP practice and don't necessarily want those visible elsewhere. Which is obviously one of the reasons why the government wants to make that absolutely available from a particular point. We'll double check whether any of that free text data is actually flowing. I don't think it is because of the challenge that you could unwittingly that some information could be shared from the GP record, which is not appropriate to be shared, if that makes sense, to other settings. So we've been really steered away from taking that free format text today. I don't think we take any, but I'll double check.
Thank you. It'd be great if it was available.
Yeah.
So Dale, I think at some point we did look at it. You said that there is some available, but then that's quite limited probably. Okay, thanks. So the next one is from Anne. So Anne, if you're still on the call, you might want to unmute.
Yep, here I am. Oh. Hello?
Yeah, we can hear you. Yeah.
Thank you. Yeah, we're doing quite a lot of work on a national core study, and we're using the Greater Manchester region as a pilot area, and we're looking at socioeconomic status, ethnicity, and job exposure in relation to, well, in this case, COVID-related ill health, long COVID, and mortality, and probably in the future looking at other work-related ill health impacts, and wondered if there was any opportunity for job role or employment status or type that could be included in health record data. Health data records, sorry.
Thanks, Anne. Richard, have we ever looked at that? Do we have anything on employment in the care record?
I mean, it's just down to what's recorded in primary care typically, and I don't think we've ever actually looked at it. I think if some people have asked, and so far we've said, technically it could be there, but I can't imagine it's going to be very well recorded, and there's going to be a lot of bias in who records it and why you recorded it. So we haven't actually looked, but there are a couple of studies where we will look and be able to sort of advise in the future about how reliable or useful it is.
Okay, that's helpful. Thank you. Thanks.
Yeah, I think just to add to that, I think that's a really good example about how we sort of cross-connect healthcare data with sort of social data, and that's an area that we need to tread carefully from an information governance perspective around being absolutely transparent about how we're using data. Because there's at what point do your how do we wouldn't it be great if we had access to other social data, for example, bin collection data, food bank data, and all those elements. But we need to be really clear about why we were accessing that data, be really transparent around it, and then we can productionize the sort of where the data is created and maintained. So, as Richard says, there may be some recording of that, but I probably wouldn't rely on it being absolutely correct. But I think this is exactly the debate that needs to happen, really, which is, we need to get to a model where we take a data story where there's a compelling case for action that is visible to the citizen, and that citizens with lived experience, which include healthcare. And from that, then elicit what data is actually required to enable that data story, as opposed to saying we've got a ubiquitous platform, we can share all data. Now, what do you want to do with it? So there's that fine balance, because we generally come across around the IG.
Okay, thank you.
Yeah, and it's one of the use cases where you could consider to go to the LSOA level, so lower super output area level. So as you probably know, that's 1,500 people. So we've got about 2,000 of those in GM. Obviously, it reduces the fidelity of your study, but from an IG perspective, makes it fairly straightforward.
And that's some of the work that we're doing at the moment as part of this Protect International Core study into, well, at the moment it's COVID transmission and our understanding about which groups and where and why they were most affected. But yeah, that's so maybe perhaps future facing there's opportunities or sort of things that we could learn from this care record, because some of the work is looking at how useful the Gmcr record is. We're doing some work on that at the moment. So thanks for that. It's really helpful.
Okay, great. Thanks. So a couple of more before we're going to finish. There's a question from Chris. And Chris, maybe you want to unmute as well. It's around whether we want to homopify the data.
Yeah, it was a question related to the research and secondary uses of the data, and whether you would migrate to an open OMOP standard, more orientated towards data that's collected in acute settings, episodic data that you record. That may be a model that kind of lends itself into what you're trying to do. So it was just a thought, and I'd like to know and understand whether you'd kind of considered that standard.
So Daryl, is that something that's on the agenda at all?
That's actually come up a few times lately, and I think with our partners in Cheshire and Mersey, we actually put a research funding bid in to do that, but sadly it got rejected recently. So it's on the potential to-do list, and that's mainly for the reasons I think you're already saying. It's around making people share things cross region as well. And part of the work we're doing with Open Safely implements a similar model as a standard sort of study definitions that Open Safely use as well.
Well, it's it takes away the proprietary kind of format of the database, and obviously they review they resolve all their codes to a standard. It may not be ideal because it's maybe US coding systems, but it essentially. This doesn't remove the data engineer's job, who still has to construct a query against the code sets, but you've got a way of sharing kind of a mixed bag in acute care into a common model, and then start to understand it a little bit better. And I think that would be useful from a data point of view, and it can also lend itself into primary care as well as I've seen it done. Okay, thank you.
Thanks, Chris. Ruth, would you like to come in?
Yes, thanks. Well, just thanks everyone for all the really interesting chat and questions in the chat. Neil, there were a couple that I wondered whether you might find time to look at. Gareth Price has asked about how the Gmcr research tree is going to change potentially with the ADSP. So, and is there any plans to do anything with that? And obviously there are, but perhaps you could share a bit more of that. And then there was somebody, and I've lost my place on it now, so sorry, I don't remember the name, but there was somebody asking about the cost model. So perhaps you could give a bit of information about that as well.
Yeah, I've got all of that on my list actually.
Brilliant.
So yes, so Caroline asked about costs. So Caroline, to address your question, at the moment, in principle, there are no costs to access the Gmcr for researchers. If you want to thank someone or send flowers or buy someone a coffee or a beer, that should be Guy, obviously, because he's all made this possible. Thanks so much again, Guy. We do ask that if you apply for funding and in that grant application anticipate access to the GMCR, that you then do write in sometime from my team, from Richard, for instance. So that's basically the short summary. Feel free to get in touch with us. So maybe Ruth, if you could enter our contact details into the chat, feel free to get in touch, Caroline, and we can talk you through the process. Then there was a question from John about long-term robustness of definitions. John, perhaps you'd like to unmute and ask the question.
Thanks, Neil. The thought occurred to me that some of these definitions are very good when they are, when they're initially made, but then if you introduce new drugs into the treatment of a condition and change the way in which you actually implement the drugs, then some of the definitions, in a sense, are going to become a bit flimsy. I don't know really, Richard, whether this is something that you want to take, or other people will want to look at that. But that's something I just felt would be maybe going to be an issue in the sort of the medium term, and not in the short term, perhaps. And obviously, the work that you're doing at the moment is going to save a lot of people a lot of time. But I'm just wondering whether the stability is there in the longer term. Thank you.
No, I mean, it's a very good point, but we're very much aware of that. So, I mean, I guess the two main things we do for that is the way we have of constructing the code sets. Rather than just saying, this is the list of codes that we need, we have sort of a way of saying, these are the sort of codes we want. So any code that mentions this, for instance, for statins, we would have a query that searched the code terminology for anything that had the word statin in it, because I think most statins include the word statin in their names. So we'd define the search of what we were looking for rather than the codes themselves. And then what we can do is we can periodically check the latest versions of the SNOMED code dictionary to see if anything has changed. So we can sort of rerun those queries, produce a new code list, and so we can update those quite easily. And because I guess it's us doing it rather than the individual research teams, then it makes it a lot easier. And then also if a definition of why someone's diagnosed with something changes over time, then again, we haven't really got any strategies for that yet, but I guess it's just a case of saying, well, this is the definition of diabetes as they used to think it was in 2022, but here's the 2025 definition when we all realized that we were doing it all wrong for the last 50 years. So yeah, it's definitely something that we're aware of.
Great, thanks, Richard. So then there was a question indeed from Gareth. So maybe Gareth, you want to unmute and ask the question.
Thanks. Yeah, just I heard in passing about the ICS data analytics platform. Matthew Hennessy, I think, and he passed me some documentation that I looked at, and it seemed that it was either did or there was plans for it to interact with the Gmcr record. And I just wondered if you could comment a bit further on plans going forwards with that.
Yeah, thanks, Gareth. So basically that platform, what's available there is largely complementary to what's in the GMCR. So for instance, it holds the SUS data that Guy mentioned earlier. So what we're doing indeed is trying to integrate that with GMCR in a new infrastructure. And Bradley Quinn from Health Innovation Manchester has been leading on that. So Guy, maybe you want to add something to that.
Yeah, no, absolutely. Yeah, first of all, the flowers should go to Paula and the team, not me, because they've done the hard work, not me. But thanks for the shout out, Niels. Yeah, so what we're building is an integration between that broader analytics data science platform, as Niels talked about, that's got more data sets within it, and the bi-directional integration between that and the Gmcr record analytics platform, so that we're really clear that when we, for example, do a case finding capability, which may involve data sets which sit outside healthcare, how can we then iterate that algorithm into the hands of people that can take action with the algorithm, so it go from the ADSP to a flow into the the analytics platform from the Gmcr, which will provide a targeted list of patients that would then be surfaced in the GP workflow as an example. So we're building that sort of bi-directional sort of integration flow. So they're very much sort of complementary. So you think of the Gmcr analytics platform as being a sort of a key data asset that fits into the wider analytics data science platform, of which there will be a trusted research environment, which I'm sure that Niels has already talked about, overriding all those platforms.
Okay, so final question is from Stuart. So Stuart, maybe you want to unmute.
Thanks, Niels. Yeah, it was just I guess my experience is where does research end and service improvement begin, and they can be quite fuzzy boundaries. And I think one of the really positive aspects of the TRE is the ability to generate clinical algorithms on real live clinical data, which is really powerful, I think, could be really helpful to improve cohort finding for patients that are hard to reach, don't get the equity of referrals maybe that they should have. So all very positive. So I just wondered though, what's the process, or is there a best practice then for how those algorithms are actually then deployed back into care, rather than that becoming a bit of the Wild West, especially if people were sort of dropping in black box AI solutions into that may introduce all sorts of biases. So any advice as we start on the journey? I don't know if that's a Guy or who Paula or anybody has any thoughts on that.
Well, I'll start. I mean, I'll defer to my sort of data science research colleagues from the university, because it's an interesting area, really, isn't it? Which is, you know, at the moment, you know, I think it's fair to say that even if we did very simple, straightforward case finding, that would unlock a whole lot of benefit. Even if it, you know, so it's like very, you know, search these particular codes to get this patient's at would release a lot of benefit. You know, then having much more structured sort of algorithms that go through rigorous testing all the way through to AI that constantly change their algorithms. You know, I think there's a whole world of certification and validation that needs to be sort of cut through around that. And I think there was an interesting model, I think, from the US that sort of said the degree of self-learning versus the impact that decision has on clinical care. So if it's highly automated and it could kill somebody, that's high risk. But if it's highly automated and it's, you know, it's just a logistical process, then it's low risk and there may be more appetite. But I don't know, Niels, whether you've got any specific advice and guidance in this area. It's more your space than mine.
Yeah, I personally think it's a great question, by the way, Stuart. And I think that, you know, this is a fantastic opportunity for the Greater Manchester Care Act to do exactly that, right? So there's the opportunity for translation, which I think if you look at the literature on data science, health data science, and AI and machine learning, you know, very often things don't translate, right? So people develop fantastic algorithms and they're published in fantastic journals, but that's where it stops. They never actually reach patients, clinical services. So we've got the opportunity to do that. There is obviously all those concerns around safety, transparency, all those things. And I think regulators are clearly stepping up to move into this area and make sure that things actually tick all those boxes. And it's also a very active area of research to make sure that algorithms do that. But what really excites me is that, you know, with the Gmcr, we've got the opportunity to do this, and also in fairly short cycles. And we haven't got, you know, an established process to do it, I would say, but I think we should develop one. And SMASH, which was mentioned, and also Brde and SMASH, which were mentioned by Daryl, are good examples of things that came out of scientific research and then were translated into services embedded in the Gmcr and now deployed across Greater Manchester. And I hope we can do that with a lot of studies that are now being conducted by researchers on the Gmcr, but eventually make it to services that actually improve, have tangible benefits to the GM population.
Thank you.
Right, so I promised to give you back 50 minutes of your life, and that has already shrunk to 9 minutes. So I'm going to stop us here. Thanks very much for joining. Thanks especially to all our speakers today. I think it was a really great session. And like I said at the beginning, GMCR, a fantastic example of the type of collaboration that we can have in GM. And thanks everyone else for joining today. And I hope to see you in a couple of months' time. Maybe before we go, Orla, do we already have a date for the next ecosystem?
Yes, we do. That's on the 10th of June. So we'll be sending out some more information on that soon and how to sign up. I'll just drop the newsletter sign up link in the chat now for anyone who wants to keep up to date on that.
And that is going to be an in-person meeting, isn't it?
It is indeed.
Yeah, so, well, excited to see you there in person. Thanks, everyone.